We are really happy and so appreciative of the two physicians that we have up next, who will be talking from personal experience on the front line in dealing with COVID-19 from a hospital setting. And if you know anyone that works in a hospital, you are probably well aware of what a different take they have on things than some other people. So I am happy to welcome our next two presenters, two physicians, Dr. Sam Antonios and Dr. Chloe Steinschauer. Dr. Antonios is an internal medicine physician and has been in leadership positions for 13 years, and he currently serves as the Chief Clinical Officer for Ascension Via Christi Health System. Dr. Steinschauer is a physician at the Pulmonary and Sleep Consultants of Kansas and is a medical director for Medical ICU, Critical Care Services, and Respiratory Department at Wesley Medical Center. And I am just going to go ahead and, first of all, thank you both for being with us today. And I'm going to turn it over to you, and you can take it away. Thank you.
Thank you. I hope that people can hear me. It's always good to test these things before start talking for a long time and realize I don't hear you.
We can hear you.
Okay, good, perfect. Success number one. So actually, Chloe and myself don't really have a actual slide deck presented or anything like that. We were hoping to give you a little bit of a background and some information about the last year and what as health system physicians have dealt with on the front line and from a leadership perspective. I did ask before the meeting about what a kind of the area to potentially go towards, just in my comments, knowing the audience and just listening a little bit to the presentation earlier. Obviously, it seems like the audience is mostly involved with businesses, employers, and HR related topics. So I'll try, if I can, approach those from that perspective. But I'll also say that I'm more than happy to answer any question. It looks like there's an active audience trying to present or using the chat feature. So any other way to ask questions in the time allotted to us, I'll be happy to do that. And so, Chloe, do you want to start? Do you want me to just go real quick, or?
I think it's fine if you want to start. I assume questions are probably much more.
Correct. So we're hoping that maybe the conversation is via some Q&A. Real brief, so I'm announced, I'm the Chief Clinical Officer for Ascension Via Christi. Very honored to be part of this community. We obviously have been here for a long time, and when the time came for us to step up to assist the community in battling COVID-19, we were ready to answer that call, and I'm very grateful to our medical staff, such as Dr. Steinschauer, who and other physicians who really stepped up and have been carrying us through this period. Just real brief, I'll mention that we have, as a health system, Ascension Via Christi has handled in the state of Kansas the highest number of COVID-19 patients, just looking at some CDC statistics. And yes, for those of you wondering if more than KU Kansas City, yes, we did as a system see more than those patients. Wichita for a little while was actually so busy. It was, even now Sedgwick County is higher in total count than Wyandotte County. So really our area did see quite a bit of activity of COVID-19. We've had a system of about 2,500 ED visits related to COVID-19 at least. That's just by latest count. It's been a while since I looked at that. And we've had another 2,500 on the hospital side, at least within our system. So with that said, obviously we acquired a lot of expertise, but also have leaned a lot on other systems and others to learn of how to deal with this. And I'm very grateful, like I said, to everybody who has pitched in and has been of assistance to us. Right now, we're focused a lot on getting vaccine into the community. We are I personally believe that the worst is behind us, and every passing day is another brighter day. But it really will all depend on getting the vaccine in front of people. And you might have heard about the vaccine challenges going on now in the nation from a distribution perspective. And it will potentially be an ongoing struggle for a little bit, but vaccine, I've got that percentage that they have on the KDHE website. I told my wife when that hits 65%, I'm booking a trip on an airplane. So that's the goal, is to try to, and obviously we want it to be higher, but that's my minimum. So what can employers do? And these are just a brief questions kind of to jog the conversation that I received before the conversation. I'll just mention what can employers do to be helpful to the medical profession and to hospitals. And really simple is what you've heard all along, which is to encourage as much as possible social distancing, washing of hands, and the use of masking at all the time. Those have had an impact, and they continue to have an impact. And part of the reason that we are now doing better is, since the fall, is because there's been finally more adoption of those measures in the community. I'll just, there's a series of questions here, and I'll jump straight to the one that has, actually one of the last one was interesting. Has mask wearing had an impact on flu prevalence, and could that strategy be utilized in future years? Oh boy, it's weird. This year is, when I look at our admissions, obviously this is just hospital-based data, our admissions for acute viral illnesses, influenza A, B, parainfluenza, human metapneumovirus, these are kind of type viral illnesses that typically can kind of nudge someone into the hospitalization. They're almost gone. They're not completely gone, but they're almost gone this year. Replaced, unfortunately, by a more morbid and lethal disease, which is COVID-19. But if I were to attribute those to something, it would be obviously the vaccine, the flu vaccine that has been adopted, and two, not a lot of interaction, because a lot of those are droplet type of viruses that are that spread from person to person. And because of the overall approach this last winter, thankfully those numbers have been reduced. So there is an argument for, I guess, more of the same measures, maybe not to the same extent, in order to control the other viral illnesses. And then, how can employers encourage their employees? Every possible ways to get the vaccine. This is a good vaccine. We're really dealing with a very good vaccine, both of them right now, Pfizer and Moderna. They're a breakthrough, and there's no better year for them to happen. More than happy to engage with anyone who has questions about the vaccine, because these are really game changers and revolutionary. So with that, Dr. Sanchar, I'll leave it to you to share also part of your experience. And obviously, like I said, we're both happy to entertain any question and take the conversation wherever you think it needs to take us.
Thanks. So as they mentioned, and Dr. Antonios mentioned, I am a pulmonary and critical care physician. So I am right on the front lines of this. I take care of the sickest of the sick with this disease. We've been taking care of these patients since March 17th here in the city. Over that time, we have seen a rapid escalation to the end of November, beginning of December, where our hospitals were clearly taxed past their normal stretching points. That's about the same time as Dr. Antonios mentioned that we had a much more mandated masking mandate that was being enforced, and much better social distancing behaviors on the part of the community when they started to see the taxing nature that was happening in the hospital. And with that, we have seen a significant change in our numbers over that time. That said, this is a weird disease. It's unlike anything that we've ever taken care of before. These are some of the sickest people that I've taken care of in my career, and I've been doing critical care for about 12 years. So what I think is the hardest part here is those people, there's a lot of illness that isn't seen in the community. There's a lot of misinformation that's been spread about this disease, and there's a lot of misunderstanding of what it can and can't do. I think the hardest thing to recognize is everyone's so focused on how deadly this disease is, and it is significantly more deadly than the things that we normally deal with at this time of year. So flu is a bad disease to actually get if you're hospitalized with it, but it disproportionately affects very old or very young populations. This disease, on the other hand, has some sort of predilection for affecting working age folks. So I will tell you that those that I have seen in my ICU have been anywhere from the age of 18, which is the youngest that I take care of, all the way up to 104. Most of my patients who are in the ICU and stay there are between 40 and 60. So these are people who are in the primes of careers, who are, your highly experienced workforce. And so what we're also hearing from folks is how businesses are being impacted because they're losing their work staff. From an illness perspective, that also affects healthcare. So our healthcare workers are being disproportionately affected by this. We're losing nursing staff, we're losing physicians, and we're losing them for multiple reasons. Number one, they're getting ill. So when you have high exposures to this, regardless of your PPE, there's an increased risk that you're going to contract the disease when the disease is so widely spread in the community. We're also people who live here, so we're at higher risk from contracting it, especially since we have to be out and about. And then we're also losing lots of staff to attrition because it's so emotionally overwhelming. And I think Dr. Antonios can account for this. We have both systems have implemented aggressive policies to help, well, actually programs to help with staff. What we're seeing is a PTSD type scenario where we're losing experienced staff because of the sheer, not just volume of work, but the severity of illness. We're losing young people, we're losing people in really traumatic ways. And so the difficulty with that is really affecting your healthcare staff. And what we also are dealing with is this rapid progression of knowledge. So we have to stay up to date on things that are changing on the fly. Dr. Antonios mentioned the vaccine. That is our best weapon against this. We have the opportunity in a novel virus where we have no known immunity to create a baseline immunity that can reduce severity of disease and reduce transmission. So the premise of the vaccine isn't that it's going to prevent you from getting it 100%. What it is going to do is reduce penetrance into the community, which means if fewer people have the disease, fewer people can spread it, and then the disease starts to die from attrition. There's less vectors to pass it to, so I can't give it to somebody else if more people are protected. This vaccine technology, mRNA, there is a lot of concern about it. There's a lot of people who are worried because it came through so quickly. That was the result of a perfect alignment of factors. This is a huge exposure disease, which means there was a huge population and a high contagion risk. So you have a vaccine that can rapidly prove its effectiveness because there's so much risk of contracting the disease. mRNA technology and these vaccines has been around for about 2 decades. We've all been waiting for them to come out. And then in Nature in 2018, there was a fantastic article talking about how this technology works and how this could be successful. So I will tell you that my colleagues and I who were waiting for this were first in line to get this vaccine because we were ready for it. We were waiting for it, and this technology is extraordinary. If you think about the effectiveness of the typical vaccines that you're taking for viral illnesses, think of something like the influenza vaccine, and you'll see a variable protection rate anywhere between 40 to 70%, depending on how well it is matched. The mRNA vaccines that we're seeing have an early protective capability of 90 to 95%. That's pretty spectacular for a viral illness that has a rapid shift. As these new variants come out, the vaccine still seems to show some protection against them, which is also exciting news. Also, mRNA technology has the ability to rapidly adapt to help protect against those, and both companies are already pivoting. So BioNTech, which is Pfizer, is the Pfizer colleague, and then Moderna are both working to rapidly develop new antigen protection against the South African, the Brazilian, and the UK variants that are seen. I see a question asking about BAM. Bamulivimab is the Eli Lilly monoclonal antibody. And so the premise of this is that high-risk patients who get exposed and are positive for COVID-19 infection, but maybe have early or minimal symptoms, what can be done is in the early stages of disease, they can be given an infusion of monoclonal antibodies. So these are external antibodies designed to help fight the infection early. And there's some early signal data that may actually be protective at reducing hospitalizations and death. It's had what I would argue is a signal rather than a true reduction in hospitalizations. Part of that has to do with utilization. It's not super easily accessible. There's not a great predictive model that tells me which patients were actually going to go to hospitalized disease in the first place. So that's going to require more study to see if it actually is decreasing hospitalizations. A lot of anecdotal data coming from places that are using this broadly says that. However, their numbers don't quite match up to that. So the feeling is, yes, it can reduce disease. The degree at which it reduces disease and hospitalization is still yet to be seen.
So Dr. Sanchar, I see there's a question from Jackie Kenner. What's the biggest lesson that has been learned by the health system? And this is in relation to future pandemic. There's a lot. To me, I've told people, I learned early on the importance of collaboration, and I don't mean that in a cheesy way, but it became important because in the areas where we lacked collaboration, and this is when I'll give you an example, when we started seeing that federal and state responses were not similar or not aligned, systems were struggling, trying to secure PPE, trying to secure ventilators. But the areas where there was collaboration, either amongst hospitals, amongst providers, even at the small level, amongst the medical staff or big health systems, it did pay off, and even just sharing of information. So in order to kind of future-proof from future pandemics, the healthcare system, more infrastructure around collaboration needs to exist. I've also learned, we've also kind of learned ourselves the importance of information. Now, without one, I don't really have good solutions other than, and this is another thing that employers can do in order to improve the adoption of vaccine, is to turn off Facebook and Twitter. I say that obviously jokingly a little bit because that's impossible, but it's amazing the amount of misinformation that just quickly swirls, and it became hard to have a good signal amongst the noise, and the signals were drowning. Unfortunately, people are, or maybe fortunately, this is by nature, we're kind of dichotomous. We tend to classify the world around us as good or bad. So people just wanted to kind of take a position. And I would tell people in our command center, we have to get used to the gray. We have to accept the nuances sometimes. Yeah, this disease can be bad for a certain population, but at the same time, we have to acknowledge that about 99% of the people who got it actually did well. And so people have a hard time reconciling, how come you're saying that it is a terrible virus, but at the same time, you're agreeing with me that 99% of the people actually do well. But that's reality, that's math, that's statistics, and there's a lot of gray there. And there are people young people like we have in the hospital today, someone just got on ECMO last night, young person, she's now on an ECMO device, which is kind of basically artificial heart pump. Bad disease can happen as well. So it was, because we're dichotomous, it's a fertile ground for misinformation to push people into one side or the other, when in reality, it's a lot of gray and it's a spectrum, and we have to learn how to live with it. So those are my lessons, is the importance of collaboration, and how can good information reach people in a good way without it being somewhat distorted. And I don't have an answer for that, frankly. Any other questions from the group? In fact, maybe Shelley, you can remind us a little bit of our time slot. I don't know. I don't want to make sure we don't go over our time.
Oh,
I can go through other topics. Huh?
No problem. We actually have until 12:30. You
okay.
Need to go. I mean, I have a few things to say at the end, but that's it. We do have one question. so far in the chat box, given the risk of a poor outcome for those patients who also have obesity, should we be more aggressive about treating obesity with pharmacologic agents?
I'll field that. I would argue no, because pharmacologic agents have not been shown to sustain or provide a metabolically successful weight loss. So yes, we should be aggressively working after obesity, and we should be aggressively looking at lifestyle modifications and preventive care. And I think one thing that this pandemic has certainly shown is that there are huge health disparities that are socioeconomic and racial and sex related. And we're seeing that in outcomes. There are also huge variations in how people do with this disease. Obesity is an epidemic of its own right, and it's one that's very difficult to treat. So from a health perspective, I think everybody always hears about the health elements of it. From a hospital perspective, let me give you a second element. These patients in my ICU are all turned upside down. One of the things that we have seen that changes outcomes in this is to lay people on their stomach. That means we lay them on their stomach if they can move themselves to that position, and it means we lay them on their stomach if they are on a ventilator and sedated and unable to do it by themselves. That means my healthcare staff has to coordinated turn them and lay them on their belly. That's very difficult in its own right, and it becomes much more difficult when a patient weighs 500 pounds. So we also require special equipment. There are dosing of medications that have to be considered in that population. So as part of the planning, when we see a population increase that has special needs, whatever it may be, and in this case, diabetes is disproportionately displayed and obesity is disproportionately affected, then that has to change your planning of how you care for patients. And so you have to look at, as Dr. Antonios was talking about, this collaborative planning. This involves our pharmacy, it involves our environmental teams, our supply chains, looking at, we had to get additional bariatric beds or additional lifts so that our teams could provide the appropriate care and make sure that while we're helping these patients bridge through this process and try to heal, that we also aren't harming them by allowing them to lay in a bed or to develop bed sores or to have injuries. And then we also have to make sure that we have a sufficient amount of appropriate equipment for patients who, for whatever reason, require different monitoring or different care. So with obesity, you may require longer tubing or catheters to maintain appropriate positioning of those devices. So yes, we need to manage obesity. I would say pharmacologic is not the direction to go. I think that aggressive wellness programs within the community, I think preventative care being prioritized in the healthcare system would go a great deal for helping the overall healthcare system from being burdened on my end, which is really the last resort segment of care.
Right, right. Okay, thank you. And I did have one, there's actually another question, and I had one as well I wanted to ask about. I had heard that, and I don't know what is happening here in Wichita, but is there still a shortage of PPE? Or are you finding that's not the case here?
Not specifically, no. We have been provided excellent support from the community with regards to PPE, and as PPE production increased, we've not had shortages. I think internationally, there are still items that we are still using PPE devices in ways that maybe they weren't initially devised to be used, but have been proven over this time period to be reasonably safe. So before the pandemic, it would have been considered an anathema to put on a N95 mask more than one use. If you took it off, you wouldn't replace it. So we do extended wear masking and things like that, which is a different, but not necessarily problematic protocol. But as for all of our other equipment, I would argue that at least our facility, and I feel like Via Christi as well, have done very well at maintaining appropriate and safe PPE for healthcare staff.
Right. Dr. Antonios?
Yeah, no, the PPE situation thankfully has improved significantly. And, I actually credit a lot of our sourcing group, or it's called the resource group. It's a team that is our supply chain team who has worked hard on getting the PPE. It's a lot better now. It's generally not as much as a problem, with a few caveats, and I'll tell you here in a minute what they are. It is, though, a lot more expensive, and that has continued, as you can imagine. Obviously, optimizing out revenues for supply chain companies, and its demand that has increased significantly. So we are paying probably 3, 4, sometimes 5 times the same supply from a prior year. And so, no, they're available. They're coming at a premium, though. There has been a few outbreaks in some of the manufacturers of gloves, I've heard, in Thailand, I think, or in other countries. And so periodically we would see these challenges with getting a specific item. And so we have a team that's basically every week telling us, look out, nitrile gloves are now problematic, but then a couple of weeks later improves. And so they're tracking this all the time. I can imagine how potentially a smaller provider who doesn't have a big GPO, or maybe don't have the resources of a big supply chain, may struggle because they can't hop from one vendor to the other, potentially. Maybe that's still occurring. We're thankfully, being part of a large system, have been able to overcome that. But in general, it's no longer the everyday conversation that it was early on.
Okay, great. I have another question. How long, and this would just be for both of you, how long do you anticipate we'll need to wear masks, be socially distant, etc., given the immunization timeline?
That's a very good question. Here's a couple of things we don't know, and because we don't know, it's why you will find that most health experts, and at the CDC, the local level, even I think Tony Fauci said it himself, we know that the vaccine is effective in preventing the individual from getting sick, him or herself, at 95%. So there's still there's still 5%, but there's mostly successful at that rate. What we don't know is, when you may not exhibit any symptoms and you're fine and your immune system has blocked off the virus, could you still harbor vaccine in droplets and spread them to others? So you
harbor virus, not vaccine.
I'm sorry. Yeah, virus. I misspoke. That would be kind of weird. Although it would be effective to spread vaccine that way. So yes, the virus. Yeah. So what we don't know is, so you get exposed to a virus. Now they're kind of in your nasal cavity. You don't get sick, but are you still spreading it to others? And that's I'm not saying that's happening. We just don't know. Because of that unknown, a lot of people are saying we need to continue, not change anything at all on the social distancing and masking. On top of that, if you look at the percentages in the country right now, I don't know if we hit 10% hit on vaccination. I think we're lower than that. I haven't looked at recently. I know Kansas is only 4.5% according to KDHE. So to achieve a significant level of suppression of the transmission of the virus, we need to be hitting at least 65%. And that's at least. In fact, I think Fauci has mentioned something he would like to see 80 and 90%. So
reasonable expectation based on how this vaccine works and what they call the R naught, or the infectivity of the virus. The estimate is that 75% of the population needs to have protective mechanisms. And so with the degree of infection that we've seen through the country, that's still close to 70% of the country needing vaccination for reasonable protection. And at that pace, what we'll see is probably a reduction in disease spread, but not control. So every international healthcare organization, and as Dr. Antonios mentioned, every local and national organization that has any sort of modeling data is suggesting that 2021 will probably be a masked and distanced year.
Right. Okay, I had a question, and that is the long-term effects for some people. And I have 2 daughters-in-law that both work in hospitals, and a friend that works in a primary care practice. And I'm just curious, I'm hearing about patients that come in, particularly in the primary care practice, that are having ongoing issues, particularly lung, cardiovascular. Insight into that. I mean, how prevalent is that? Any feedback you have?
So, yeah, I'll go with that one again. The number of patients who have been hospitalized with COVID and have long-term effects of any type is over 90%. The number of patients who have had even mild disease and have long-term effects is nearly 50 on most recent surveys. Degree of debilitation or problem varies wildly. I will tell you that as a pulmonary physician doing pulmonary function testing in my office, it is almost universal that there is lung loss after COVID, whether you had symptomatic disease or not.
Wow.
So we are also seeing long-term cardiovascular effects. We are seeing a signal that there's an increase in heart failure in communities, meaning that the expectation is that we'll have secondary admissions coming from people who have secondary heart complications. The most common effect that people see is actually neurologic. So what we have is a huge increase in brain fog, which is a catch-all term for people don't executively function as well as they did before. You see sleep disturbances in these people. You see a lot of inability to focus, or examples would be making silly mistakes with addition, forgetting how to remember, or forgetting phone numbers, having difficulty with people's names, having difficulty recalling your schedule. Things that will happen after you've had a rough night or you've had a bad sleep, but they're having this and it's protracted for days or weeks at a time. And this is something that doesn't have intervention. And for some people, it has proceeded to extend for over 6 months. So there's people that they're following long-term to see if it ever resolves. So that is still an area of research. It's still an area that's unknown what the severity will be. But the expectation is that COVID itself is really ugly and it gives people bad complications. Even if you don't die from this, it can cause trouble for you. And it can cause significant problems even if you only have mild disease and don't ever need oxygen or hospitalization. So there's still sort of this argument that maybe we should be trying to get natural immunity and getting, just let it run through the community, let everybody get antibodies and we'll be fine. I think what people forget there is that you'll overload a healthcare system in a separate way, because now primary care offices and all of our frontline defenses are going to be seeing people with a multitude of complaints that are very difficult to treat.
Yeah. And I don't have a lot to add to Dr. Stanschauer. We've seen those cases. In some cases, they've been kind of, in a non-official term, been called long haulers. They certainly exist. We've seen them. They come back to the hospital. It's the body's interaction with this virus is new. It only started less than a year ago, which means that all human genes are reacting in a way that is somewhat unpredictable right now, and only time and further research will show us the true impact. So hopefully with less infections every passing day, we have less of people exposed to such impacts. Certainly we've had patients who have related their struggles that just can't get over. And there's a difference here, like Dr. Stanschauer, between mortality and morbidity. Mortality is easily measurable. It's a number, and it's on the KDHE website, it's on the CDC website, but it by itself doesn't give a true story of the morbidity, which is just impact on health. That's not measurable easily.
And then I wanted to add something, I think, that probably ties into this same topic. So this goes back to the discussion of vaccination. Is vaccination as good? What happens with the side effects of vaccination as compared? There are side effects with this vaccine because it's an immune reactive vaccine. It actually is, the way mRNA vaccines work is, mRNA is how we make proteins. It's like a copy recipe that our body uses to make proteins. This technology drops a scrap of messenger RNA into the cell itself, but never integrates into the nucleus. So there's no way it can change your DNA, which is one of the prevalent myths about this vaccine. It drops this mRNA into your cell. Your body uses its own mechanisms to make proteins, and that protein is a mimic of the spike protein, or the antigenic protein on this virus. So it's what your body recognizes when it comes in. And it creates T cell, B cell immunity, and it also creates antibodies. What this means is you've built your army ahead of time. So if you're ever exposed, your body can go, hey, look, I recognize that, it's bad, kill it. What that means for a vaccine, though, is that you will feel bad. So the initial vaccine, it was much less. The second booster vaccine, obviously you already have some pre-built antibodies and it's more. Anyone who's had COVID, it's a higher rate. And anyone who's received antibody therapy will also have higher symptoms. What you get usually is sore arms, swelling, chills, fevers, or aches. And the second, you'll have a higher degree of those symptoms. What we've seen, though, is in those people that they've been studying for 6 or 8 months, they don't have any of those secondary complications that people who had COVID, who got antibodies, did. So you're not seeing the brain fog, the smell and taste changes, the cardiac complications, the increased risk of clotting, the lung damage. So the difference between the innate immunity or the created immunity from a vaccine and the natural immunity from an infection, they give you similar protection for 3 months. The vaccine appears to possibly have better long-term protection, but it does it without the cost of secondary damage to the cells. What it does do it with, though, is you feel crappy for a day or two after that vaccine. So one of the things that hospital systems did was they tried to stagger their staff. So staff that worked in the same area tried to get vaccines on slightly different days. So for example, my group, not all of the pulmonologists got the vaccine on the same day, so that if anybody did get sick, nobody was, we had coverage. We weren't all sick on the same day.
Right. Yeah, that makes perfect sense. Well, I know you all are very, very busy, and we are about 3 minutes from being done with our conference. I'm not seeing any other questions. I wanted to allow you any last comments you have. I just want to let you know how much we appreciate not only the time that you spent with us today. It was great. I think people need to hear from people that are actually working on the front lines to get a better sense of what this really is, and but also just for what you do. I think I speak for all of us. Thank you so much for what you do and the sacrifice that you've made for all of us.